Good afternoon. My name is Harendra Vijay-Sundra. I'm the Vice President of Medical Devices and Clinical Interventions at CADTH. I'd like to welcome you all to this Evidence to Action session. I'd like to start by acknowledging that the land that we're meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Hunan, Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. I also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit and the Williams Treaty signed by multiple Mississaugas and Chippewa bands. Today's session is being co-hosted by both CADTH and HQO and is built around collaborative work that our two organizations have done on a health technology assessment on internet-based cognitive behavioral therapy for major depression and anxiety disorders. Briefly about our two organizations, CADTH is an independent not-for-profit organization with a mandate to provide Canada's healthcare providers objective evidence on both medical devices and drugs on their optimal use. We are funded by the federal, provincial, and territorial ministries of health, and also we take fees for 3 of our services as shown here. HQO, soon to be part of Ontario Health, produces health technology assessments and makes recommendations about which health services should be publicly funded. And all of their technology assessments and funding recommendations can be found on their webpage as seen on this slide. Mental health is a clear priority in Canada at the federal and provincial levels, and specifically access to care. And that really is the focus of this work in order to provide and help make decisions around this issue. This team was done in collaboration between the two organizations, and it gives me a great deal of pride to show the large team that did this, which really was a collaborative project between our two organizations. Now, to everybody here in the room in Toronto, there'll be a lot of time for questions at the end, and I'd ask that you come up to the mic and introduce yourself when those questions happen. And I believe we have almost 600 people online. If you have any questions, please email them to ashleyb@cadth.ca. So that's ASHLEYB@cadth.ca. And so with that, it's my pleasure to introduce you to your moderator for this session, Effie Hillis, who is a Knowledge Mobilization Officer at CADTH. Over to you, Effie.
Good afternoon, everyone. Thank you, Harendra, and once more, welcome to our Evidence to Action event this afternoon. Again, my name is Effie Hellis, and I'm a Knowledge Mobilization Officer at CADTH. I would like to acknowledge the attendance of all of you who are here with us today in Toronto, as well as the many people who have tuned in from across the country for this event. So welcome and thank you. Our main goal for the next 90 minutes is to use the collaborative work that CADTH and HQO have done on iCBT and use that as a platform to further understand iCBT and explore the current landscape in Canada in terms of accessing mental health support outside of a therapist's office. We hope to engage all of you in a conversation around experiences with iCBT and how it can be incorporated or implemented in the care pathway for mental health disorders. The session today is meant to be an introductory session to iCBT. We're going to try to cover different perspectives from across the country. We hope, however, that we receive questions from you, as it is very important for us to know what the needs are across the country, and we can further focus our future events when it comes to implementation of iCBT. So please ask questions. The online system may not work very well for us today, but as Harendra mentioned, please send your questions by email to ashleyb@cadth.ca, ASHLEYB@cadth.ca, and for those in the room, there will be a microphone, and please feel free to ask questions as well. So and at this point, I would like to recognize, we would like to recognize the availability of a number of iCBT programs in Canada as well as internationally. And while the names of iCBT programs may be mentioned during the session, CADTH and HQO do not endorse any one iCBT program over another, or those mentioned over others that are available in Canada and not mentioned. So with no further delay, I would like to thank all of our speakers for today. Most of the speakers have been valuable collaborators for our HDA work, and they have contributed to our understanding about iCBT in Canada. Carolyn, David, and Patrick are joining us here in Toronto in person. Heather is joining us remotely from Regina, Saskatchewan. And at this point, I would also like to acknowledge and thank Mr. Byron Boyd, who has graciously accepted our invitation to be on standby during the discussion part of this session. And if we have time, Byron will contribute the experience in Newfoundland with iCBT. So let's get started, and perhaps we can start thinking, and we can start with a true or false question. So in Canada, mental health stigma is decreasing and awareness around mental health is increasing. So true or false? Maybe for those online, they can think about it, you can think about it, and those in person, perhaps a show of hands if you think this is true. So most people think this is true, and this is the case. And this is a good story. This is the result of a lot of work that has happened over the past few years from many groups in Canada. So right now, many Canadians are more comfortable talking about their mental health issues and seeking help for them compared to a few years ago. However, this good news story has perhaps some unintended consequences, which is more demand for services and a health system which is not necessarily equipped to deal with this demand. So we are aware of shortages of psychologists, psychiatrists, and other trained professionals. That creates long wait times. And we also know of cost issues and coverage for mental health services across the country, as well as differences when it comes to mental health services across provinces and territories in Canada. So in that context, e-mental health options could provide an additional point of access for mental health services. They could be useful when it comes to people accessing mental health services when they live in rural or remote areas, when they are concerned with stigma, or there are other issues that do not allow them to access mental health support. So in that space, we would like to recognize the Mental Health Commission of Canada, who has done a lot of work in the space of mental health. For today's presentation, we are looking at iCBT in the context of depression and anxiety disorders. And for these disorders, as most of you know, cognitive behavioral therapy is an effective psychotherapy which is most commonly used for these disorders. And traditionally, the way it works, the patient has to go to the therapist's office, and they work together to identify and develop strategies and skills to change unhelpful patterns of thinking, beliefs, and attitudes and behavior. Now, internet-delivered cognitive behavioral therapy, and we're going to hear a lot about it from our speakers, is CBT delivered over the internet. So the patient does not have to go to the therapist's office, but they do need to have access to an internet connection, and they need to use a computer, smartphone, or tablet for that. So the programs typically include a series of modules that are structured, and there are clearly defined goals for each of them. They may need to complete readings and activities as part of the program. And iCBT modalities usually are either guided, so there is a therapist that supports the patient throughout the program, and through messaging, the patient has the opportunity to connect with a therapist at certain points in time, or unguided. So in that case, it is self-directed without the support of a therapist. And with that context under our belt, I think it is time to hear from an iCBT user, just to get a better understanding of how iCBT works. So I would like to invite Karilyn. Carolyn is a design student at York University. She has had experience with anxiety, depression, and ADHD, and has previously been a user of online CBT. Karilyn was one of the participants who contributed to the HDA review conducted by HQO for the Patient Preferences and Values Review. And Karilyn will share with us a bit of her experience with her mental health journey and her experience with using iCBT. So welcome, Karilyn.
Do I click next, I guess? Oh, there it is. Hi. So my name's Carolyn Xu, that's me. I'm a student at York University and a former user of iCBT. Today, I'm just going to be sharing a little bit about my experience with anxiety, depression, and also my experiences with iCBT and how that helped teach me the skills to sort of manage my anxiety and depression. So I'm going to start my story off in 2013, and at the time I had just graduated from high school and I was in university for the first time. So I was living on my own, I was in a totally new social environment, and I was really struggling socially, and I found the environment to be a really isolating atmosphere. And after a while being in that sort of environment, I just started to feel really bad all the time. And if that sounds kind of vague, that's kind of how it felt for me. It wasn't, I didn't really understand what was going on. I didn't understand what exactly about my life was like upsetting me, I guess. But I just had this feeling that something wasn't quite right. So those feelings kind of culminated in my second year at U of T. And they culminated in me dropping out of school. And that was a really hard time for me. I was struggling a lot in school, with school work, and also with my mental health and my physical health as well. And I still, at that point, didn't really know what was going on, so I really felt that the best thing for me to do at the time would be to take some time off of school to try to just figure out, for lack of better terms, what I was doing with my life. So I took a few months out of school, and after that time, a friend of mine who had just graduated from university messaged me, and she told me that she was going to Australia for a year, and she invited me to come with her. And that was like a totally huge change of pace for me, but I decided that that was kind of just the change of pace that I needed. And so I went with her to Australia, and we decided to go backpacking for a year. And it was really through that experience and through talking with her that I discovered what anxiety was, and through conversations with her that I was really able to identify that feeling in myself. So through that time, I realized that what I had been dealing with for the last while was actually a huge amount of undiagnosed anxiety and also depression. So upon learning this, I really started to seek support for it. And my friend was really instrumental in this as well, because she had actually had her own personal experiences with anxiety, and she was very knowledgeable about the subject. So she really encouraged me to seek out support. She had actually brought worksheets with her to our backpacking trip, and she gave some of them to me, and she really encouraged me to use them. So I found those worksheets really helpful in some ways. I felt that when I was having, or the skills that they were teaching me, when I was having an anxiety attack or some sort of spiraling episode, that they were really good about helping me to kind of manage those emotions in the moment. But what I felt that they were lacking was, they were helpful in the moment during an episode, but they weren't really helpful in helping me understand why I was having an episode in the first place, and that was a big challenge for me. So in a lot of ways, I still didn't really understand what was going on. Through searching for more support, I eventually found an unguided CBT module online that was free, which was great to try, but I found a lot of the same issues with that as I did with the worksheets. And part of that also was a difficulty staying motivated, because this was something I was doing entirely on my own. I didn't have a very good understanding of what was going on still. So I just found it hard to keep up with those exercises. So through a lot more Googling and a lot more reaching out, I eventually found a guided iCBT program online. And the program was through a company called Joyable that was actually based in San Francisco in the States, which I initially had thought was would be a bit of a challenge, because obviously I was backpacking and I was in Australia, which is many, many miles away. But nevertheless, it hit a lot of the things that I was kind of worried about, and so I decided to try the program. So I enrolled in the program for around, I think, 3 to 4 months. The recommended length is 3 months, but I think I took a bit longer because I was traveling at the same time. And before enrolling in this course, I had several challenges that I experienced with like the worksheets and the unguided CBT that I was trying to sort of rectify. The first challenge, of course, was that I was traveling, and I was carrying everything I owned at the time in a bag on my back. So I really didn't have space or room to carry anything that was non-essential. So that was one challenge I found with the worksheets, was they were just really cumbersome for me to take around. So I really needed something that was convenient and easily accessible. The second challenge was that I found the worksheets, like I said before, and the unguided module to be really challenging to keep on track with, just because I was doing that on my own. So I needed something that was going to motivate me and help me stay on track. And then the third thing is that, I'm gonna just check my notes here, sorry. So the third thing was that I still really didn't understand what was going on with my anxiety and why I felt this way. So what I was really looking for was some context and something to help me understand what I was going through, and in a funny way, like explain my anxiety to me, because I just really didn't get it at the time. So I had some really great experiences with the program, and by the end of it, I really felt that I had gained a large understanding not only about anxiety and how to manage it, but also about myself. And so I just want to go into a little bit more detail about why that was an effective program for me. So the first thing that I loved about this program was that it was really learning focused, and it really gave me that context that I was searching for. The first thing that they give you when you enroll is a questionnaire that helps you figure out the severity of your symptoms and also what areas of your life it's affecting. And being able to put those symptoms into a real life personal context for me was really important, because those were things that I actually had never evaluated at the time. The second thing that they gave you was a coach, and that was the guided portion of the iCBT. And this coach was kind of available to me for me to refer to if I had any questions or if I felt stuck at any point. So she was really a huge resource and resource of knowledge for me to draw upon. And then once I had done those two things, the next step was to start the iCBT curriculum. And the first 2 lessons of the curriculum were entirely focused on just understanding what anxiety was. And that was exactly what I was looking for. And I found immensely helpful, because afterwards, I just felt a little bit more oriented with what was going on and what I needed to do in order to make myself feel better and kind of manage those things. So during this time, they also introduced the concept of like cognitive distortions or thinking errors. There's different names for it, but those became really key in doing the next step, which was the CBT exercises. So the bulk of the program was focused on doing those exercises, and that was kind of like the action-focused portion of the CBT curriculum. And I really loved that because rather than just like thinking and analyzing how I was feeling or reflecting on my experiences, it really gave me an opportunity to put those to action into my daily life. And I really liked that behavioral aspect, because I could see the changes and feel the changes and experience them and apply what I was learning to real life. So the next thing that I really loved about it was the flexibility of the program. Like I said, I was kind of approaching iCBT from a really unique situation. I was traveling at the time. I was halfway across the world, and those things were kind of, I was worried that they would be challenges in my ability to complete the program, but to be honest, they really, really weren't. And at the time, I was like, the online component was amazing because I was able to complete the program remotely from wherever I was. All I needed was a computer and Wi-Fi, and I was good to go. So that really helped with my ability to be places. The second thing was that while you're traveling, you just tend to have a really erratic schedule. And so that way I was able to do the exercises on my own time, in my own time. And also, the program being guided was another thing that was really amazing. My coach was always there to answer questions or for me to refer to. She was available to contact through text, email, or phone. So all of those things were just really helpful for me. And over time, I really developed a relationship with her because I was talking with her pretty much once a week for like 3 to 4 months. And having somebody who was like an outside source of accountability was really motivating for me to stay on track. And it felt really good to have somebody who was like encouraging, enthusiastic about my personal growth. So despite all of that, there were some things that I felt could have been better about the program. The first thing is post-program support. Finishing the program and then being off on my own was a really hard transition for me, and I did struggle with that a bit. I think there could have been better post-program support in terms of like what resources were available to me. The second thing was insurance, and to be honest, at the time I really couldn't find any Canadian sources of support or anything that wasn't covered by my insurance, and this, because it was an American, I had to pay out of pocket, which was kind of difficult for me. And then the third was a bit of a nitpicky point, but I really wish it was available in a mobile app, just because that would have made the whole experience like that much more convenient and available to me, because having a computer is fine, but it can be kind of cumbersome sometimes as well. So my final thoughts are just that iCBT was a great thing for me, and I feel like the program really taught me the skills that I needed to be able to manage my anxiety. And even though I did that program so many years ago, I still use a lot of those skills today on a regular basis. The other thing that I just wanted to mention is that I am actually back in like more traditional type therapy, and I don't think CBT was really like a solution for all the things that I was experiencing at the time, but they definitely added to like my mental health toolbox and are still skills regardless of whether they solve the problem or not. Great. Okay. So thanks for listening, and yeah, I'll carry it over.
Thank you very much, Carolyn, and thanks for sharing your experience with us and for bringing forward so many important points to keep in mind when one is looking for help and using iCBT. Thanks very much. So for the next session of the event today, we will focus briefly on covering the main findings of the HDA work that HQ and CADTH did collaboratively on iCBT. As we heard previously, 2 large teams worked on the project. So the full reports can be found on HQO's and CADTH's web pages. And for the next few minutes, I will try my best to provide the key findings on behalf of these teams. So first of all, what prompted the HDA work on this topic? We do know that there are various iCBT programs available in Canada right now. However, the effectiveness of iCBT is not well established. We do know that iCBT is not currently funded in a systematic way in Canada. And we also know that we don't have any concrete frameworks for policy or implementation and integration of iCBT into the clinical practice. So establishing whether iCBT is effective, whether it works, for whom it works, and under what circumstances, it is important for clinicians or health organizations who may want to offer that to their patients, as well as anyone else who may need to make a policy decision around the appropriate use of iCBT. So the HDA work meant to inform policy decisions around appropriate use of iCBT for individuals with major depressive disorder or anxiety disorders. And HQ and CADTH worked on this report, this review, and they did a comprehensive review of the evidence on various aspects of iCBT. So we looked at the evidence on clinical effectiveness, cost effectiveness, experiences of patients and perspectives of patients, ethical issues around the use of iCBT, as well as implementation issues related to iCBT in Canada. And the evidence that was reviewed was discussed by the two expert committees that collaborate with the two organizations and act as advisory bodies to the two organizations. So at CADTH, we have the Health Technology Expert Review Panel, or HTERP, and Health Quality Ontario. They work with the Ontario Health Technology Advisory Committee, or OTAC. So after deliberations and looking at the evidence, the two advisory bodies provided recommendations. So the HQO final recommendation, the exact wording, and the recommendation to the Ministry of Health in Ontario was, Health Quality Ontario, under the guidance of the Ontario Health Technology Advisory Committee, recommends publicly funding guided iCBT for mild to moderate major depression and anxiety disorders. And the CADTH final recommendation was, the Health Technology Expert Review Panel recommends that guided iCBT is offered to adults with mild to moderate major depressive disorder and or anxiety disorders. So you see that both organizations support and recommend guided iCBT, so iCBT with the support of a therapist. So now let's have a look at the evidence that was reviewed. Again, very quickly and without going into details for subgroup analysis or limitations of the evidence. So for the clinical effectiveness component, 7 systematic reviews that were published since 2000, plus 9 additional randomized controlled trials after the systematic reviews were completed, were included and reviewed. And based on the evidence in those reviews, the key messages were that iCBT appears to be more effective than the waiting list control, which in this case is receiving iCBT at a later time, and it is effective for reducing symptoms of mild to moderate major depression and select anxiety disorders, and it's also effective for improving quality of life in individuals with those disorders. And there was increased certainty in the evidence for guided iCBT compared with unguided iCBT. For the economic analysis, cost considerations related to iCBT were included. HQO did an economic analysis on behalf of the Ontario Ministry of Health, and CADTH adapted that model to reflect a pan-Canadian context. The primary outcome was cost per quality-adjusted life years in Canadian dollars and over a one-year time horizon. So the key message from that analysis was that guided iCBT, when compared with alternatives such as usual care, face-to-face CBT, and unguided iCBT, for the short-term management of mild to moderate major depression or anxiety disorders, may be a cost-effective strategy if one's willingness to pay threshold is between the numbers that are shown on the screen for the two types of disorders. We also did a review on patient perspectives, values, and experiences. HQO conducted direct patient consultations by interviews over the phone with 18 individuals that had lived experience with depression or anxiety disorders. CADTH did a systematic review and meta-synthesis of 24 qualitative studies on patients' perspectives and experiences. And consistent with what we heard from Carolyn, it seems that most patients accept iCBT. It's something that they like. They like the flexibility and the control they have over the pace and the location of the therapy. However, we also know that iCBT is not for everyone. And for those who like iCBT, we heard that some people may need more tailoring when it comes to their experience, so that they have something that's more tailored to their learning style, priorities, and needs. And this can happen perhaps more effectively when a therapist is available to these individuals. Also, I think Karilyn mentioned that as well. What we heard was that some people would prefer follow-up support after the program is ended, and that the interface, the usability, and the user-friendliness is important as well. For the ethical issues analysis, we reviewed 57 reports that identified ethical issues related to the implementation of internet-delivered interventions. And for that review, as you may imagine, issues with data security, privacy, and confidentiality came up, as well as the ability to establish an effective relationship with a therapist in an online environment. Another thing that came up was that while iCBT may enhance access to services and mental health support for some, this may not be the case for everyone. For example, for individuals who may not have a computer, they may not know how to use the internet. So something else to keep in mind as well. So in those cases, and to alleviate any concerns, transparency in communicating related risks or having mechanisms in place to mitigate those risks is important as well. And finally, for the review of implementation issues, CADTH did an environmental scan and a literature review of 29 studies on the topic. We do know that there is increased interest across jurisdictions for iCBT, but we also know, as we mentioned, that there is no regulatory framework or policies for implementing iCBT. Some programs are available only within one province and nowhere else in the country. So we looked at the different barriers at different levels of decision making. So for example, when it comes to clinicians, we identified that they may lack education or training on iCBT. Also, some of them may have negative perceptions or attitudes towards iCBT. When it comes to health care organizations, they may have barriers of funding and cost to establish the infrastructure to be able to offer iCBT. And on the other hand, of course, if there is a national strategy in place that provides a framework of policy and quality standards that may facilitate the implementation of iCBT, and if there is a way or strategies to facilitate iCBT incorporation into the pathway, such as stepped care approach, or having iCBT as a complement to face-to-face care, that could also facilitate implementation of iCBT. So that's the end of the review, the main findings, again, high-level overview. And with that in our mind, as well as the recommendations, let's see how we move from evidence to practice. And at this point, I would like to invite Dr. Gratzer to talk a little bit about the related work in Ontario. So we're going to hear from the clinician and policymaker perspectives. We're going to start with Dr. Gratzer, who is a psychiatrist at the Center for Addiction and Mental Health. He's the Associate Chief of the General Adult and Health Systems Division for Inpatient Care and Practice Innovation. He has published and presented nationally and internationally on digital psychiatry and serves on the editorial boards of the Canadian Journal of Psychiatry and the Journal of Medical Internet Research for Mental Health. And Dr. Gratzer contributed to the HQO HDA as a clinical expert. Welcome, David.
Thank you very much for that kind introduction. I'm looking forward to presenting some brief comments on internet-delivered cognitive behavioral therapy, and then we'll, of course, hear from others, but then it's an opportunity for us to hear your question. I understand there are hundreds of people who have registered and perhaps are watching from coast to coast to coast. Looking forward to that conversation. Let me, and of course, we might not get to everyone, and the best questions always come up immediately after the webinar is over. So if you've got any further questions, you can reach me through CAMH, david.gratzer@camh.ca, or you can tweet me on Twitter, perhaps. Let me take a few minutes to talk about where we are in terms of need and where we might go with iCBT, and then let's talk about what's the Ontario experience and what's the real-world experience with iCBT. Fair? So, first things first, let's talk a little bit about cognitive behavioral therapy. We've already heard a couple of people talk about cognitive behavioral therapy, but just to remind you, for mood and anxiety problems, for mood and anxiety disorders, there's evidence for medications, antidepressants, there's evidence for cognitive behavioral therapy. I would say they're roughly equally efficacious, though there is evidence that patients prefer cognitive behavioral therapy, and there may also be evidence of a synergistic effect. That's the good news. We know what works. The problem is accessibility. And in fact, these therapies tend to be profoundly effective. We in North America tend to look at an effect size when we talk about scientific journals and publications. Another way of looking at it would be number needed to treat. So you need to do an intervention for how many people to get one positive outcome. So to put this in perspective, if you treat 95 people who have high cholesterol, one person avoids a heart attack. That, by the standards of healthcare, is an excellent outcome. Statins are probably very cheap universally now. They're relatively free of side effects. One doesn't need to be a doctor to appreciate that a heart attack is kind of crummy. So a number needed to treat of 95 is excellent. It turns out that the number needed to treat for mood and anxiety problems is very low in terms of cognitive behavioral therapy. So for generalized anxiety disorder, it's 2.3. For PTSD, it's 1.7. In other words, very few people need to do this in order to have a lot of good outcomes. We want more people to have cognitive behavioral therapy, would be a simple way of looking at it. The flip side, though, is, as is so often the case when we talk about mental health care in Canada, while we know it works, many people don't have access. One can draw on PIAD's data, looking at British Columbia and people with major depressive disorder. For every 100 people who have depression, just 13 have access to any therapy, and that might be cognitive behavioral therapy, it might be counseling, it might be anything. So in Canada, while many people struggle with mood and anxiety disorders, relatively few get access. So makes you wonder if internet-delivered cognitive behavioral therapy could be part of the solution. We've had a fairly robust review, very well presented today. I'm just going to highlight one thing from the literature. This is for the American Journal of Psychiatry. It's the Thays paper, and Thays and his co-authors looked at a blend of cognitive behavioral therapy with computer-based cognitive behavioral therapy, and as you can see, at 6 months follow-up, so not after a week or two, but a full half year after the intervention, the inter-person cognitive behavioral therapy rivaled the blend of in-person with computerized cognitive behavioral therapy, and yet the people access so much less CBT in person. In other words, it did what it was supposed to do. It was cost-effective, though they didn't do a full analysis of that, but it was also efficacious. We should be careful always to remember that just because it seems good on paper doesn't mean it necessarily works in every circumstance with every individual. The literature is actually uneven, and part of what colors it is whether or not it's therapist-guided or not, as we've already touched on, both from the patient perspective and in terms of the analysis. Mood Gym, which is an online site, and by way of disclosure, I don't receive money from industry. Mood Gym, which charges a trivial sum, has good cognitive behavioral therapy, but the dropout rate is 84% if one went to look at the British Journal of Psychology paper. REACT is a real-world experiment done in the UK where people who were covered by a family practice and had major depressive disorder were referred, and the majority of them dropped out as well. So one can do this well, but one has to be a little bit cautious. And one of the big things that makes the difference between success and failure, at least in terms of literature, is whether or not it's therapist-guided. And at the bottom is a citation from a paper that I had written a few years ago on the topic, co-written. So what's available in the Ontario context? I'll talk briefly about the public system, I'll talk briefly about the private system, and then we'll talk a little bit about people's experiences. In the public system, we have a lot, and I've defined cognitive behavioral therapy quite broadly. So cognitive behavioral therapy might include people with a workbook, as our young colleague has suggested today, but it might also involve a therapist working one-on-one. So what's in the public system here in Ontario? You have Bounceback, which has some CBT health coaching. There's Big White Wall, which really isn't about cognitive behavioral therapy, but certainly if you look at their links and the resources, it does touch on cognitive behavioral therapy. If one thinks a little bit more broadly nationally, there's an experiment in Saskatchewan, which we'll hear about in a moment. And of course, at the institutional level, there are organizations, LINs and hospitals that are working on this. Briefly, just highlight some things in Ontario. This is Big White Wall, which I think of as being more peer support, but again, one can access some CBT resources. There's Bounceback, where people go through several workbooks. These are some of the youth workbooks. And again, it looks at some cognitive behavioral therapy techniques, though purists might suggest it's not true CBT. And these colorful slides belong to an experiment that I was involved with at the hospital level, where we tried to implement internet-based cognitive behavioral therapy free at the point of use for people who were in a clinic. I'll return to that in a moment. Of course, there's active experimentation in the private system as well. I would just highlight a few experiments that are going on, including with CBT Associates and Moreau Chappelle. And we see, especially in the employer assistance plan space, that there's some active experimentation going on today and growing. Let's shift gears for a moment and talk about what internet-delivered cognitive behavioral therapy looks like and what are some of the real-world experiments. My own interest in this is somewhat accidental. I'm not a big techie guy. We can look at my iPhone in a moment, which, by the way, isn't the latest iPhone, and you'll notice the general dearth of cool apps, or so my children tell me. But I'm very interested in finding different ways of reaching people. And we had an outpatient clinic that was very active within a public hospital, and many people simply weren't able to come to our clinic even when we converted over to a model of cognitive behavioral therapy, free at the point of use with a relatively short wait list. And different people had different explanations. We had, for instance, a graduate student who was doing her coursework at Queen's during the week, and she simply wasn't available to come to our clinic because she simply wasn't in the city. Other people had different preferences. And I should give a shout out when we talk about a project and we present, we tend to emphasize ourselves and not our team, but this was very much a team effort, and I'll give a shout out to Faiza Khalid Khan, who's now at Osler as a director, and Shauna Balasingham, who's now at CAMH with me, and both of them were very involved in this project. This was the first project in Canadian Community Hospital. We had very little funding and very little support from leadership when we started. One looks back nostalgically and thinks about how innovative and creative we were, though at the time it seemed more frustrating and filled with rescue fantasy. This is not a randomized controlled trial, but this is a real-world experiment where we offered people internet-delivered cognitive behavioral therapy or in person, and this is a DAS-21, and you see patients are roughly about equal in terms of burden of illness when they start, but then you notice that they do well with the internet-delivered cognitive behavioral therapy across several measures, including depression and anxiety. So the first column suggests illness, and you notice it drops, and then you notice across different aspects of their experience, whether it's depressive or anxious, and the columns drop. That was not statistically speaking, nor did it need to be. The point was that we were able to offer this free at the point of use, and it was another tool in the toolkit. Was it for everyone in every circumstance? Absolutely not. But as a provider, what was fascinating to me was that lots of people were interested in this. People you would think of, people who use, who approach the world through their smart devices, say of a certain generation, but also other people. So we had the graduate student who suggested geography was an issue. With people who did shift work who suggested this was more accessible. We had a single mom of 3 who suggested that this was the only way she could do CBT because she had to be with her kids during the day. What are some challenges? Well, there are a lot of challenges, and we've already touched on them. Our experiment was done at a community hospital because we chose to do it, and we eventually had some support from hospital leadership. But in fact, many people aren't able to get this because it's not covered in most provinces. There are some larger issues as well in terms of legal and ethical. I'll just focus on one thing, and of course, if you've got questions, we can discuss it as we move forward. But as we talk about digital interventions, it's very important for us to think about privacy and how that looks in a digital world. Let me just give you one example. All of you will realize the importance of the hospital record. At the hospital I'm at, we think an awful lot about our hospital record. Of course we do. People come into our emergency department, they explain very personal things, perhaps even including trauma. We write it down in the electronic health record. We take these things very seriously. But more and more, our patients go online and they download apps, and they put personal things in those apps, often without thinking as to whether or not that app even has a digital privacy policy, often without thinking what that means. Taurus did a recent review that was summarized in the Washington Post, where they looked at 33 apps covering depression and smoking cessation, and some of them included cognitive behavioral therapy techniques and even more than techniques. The majority of those apps sold information to third parties with or without people's approval. So as we move forward and we think about digital solutions, it's also important to think about issues we traditionally don't think about, which is, what does privacy look like when our iPhone carries our thought log in it. These are my prepared comments. Delighted to consider your questions and comments as we move forward. Thank you very much.
Thank you very much, Dr. Gratzer, for these perspectives. We will now complement your presentation with a perspective of a policymaker in Ontario. We will hear from Patrick Mitchell. Patrick is the Director of the Mental Health and Addictions Policy, Accountability and Provincial Partnerships branch in the Mental Health and Addictions Division of the Ontario Ministry of Health. Prior to joining the Ministry of Health, Patrick was the Director of Social Policy at the Ministry of Indigenous Relations and Reconciliation from 2013 to 2014, and he led the transformation of Ontario's child and youth mental sector from 2014 to 2017. Welcome, Patrick.
Thank you very much. I should say that I led that transformation with a numerous number of partners in the sector and helped to guide that process along. First, let me say thank you so much. Maybe we could see if I can get my slides up, if I went this way. Lovely. So thanks so much to all of you. Thanks to CADTH and HQO for helping to organize today. So I'd like to talk to you about a couple of things. The first is I'd like to talk about how the province is thinking about iCBT in the broader context of some MHA transformations that we're thinking through, so some of those priorities, and also how that we're trying to think about implementing a pilot for iCBT in the most effective way possible. So giving you some context and then starting to work through some of a pilot implementation. So first, the contextual piece. The first thing to say is that mental health addiction services are the focus, a big focus of Ontario's government, and there's a commitment to invest $3.8 billion over the course of the next 10 years. The idea being wanting to make more of those services available to the public. A strategy has been in formation over the course of the last year and a bit to meet that investment promise. Essentially, Minister Elliott and Parliamentary Assistant Martin have been around the province. I think they've been to about 20 different locations, meeting with different elements of people in each community. They're meeting with typical healthcare service providers, but also beyond healthcare, meeting with municipalities, meeting with police services, meeting with teachers, and really trying to understand and get advice on what are the investments that are needed and what are the transformations that we should be thinking about. I should say, of course, Indigenous partners, people with lived experience, and Francophone partners were key elements of that process as well. Should also mention, for those of you who aren't from Ontario, that we have a relatively new Associate Minister for Mental Health and Addictions, Michael Tobolo. He's been really influential with us in deepening some of the conversations that we've been having with our partners across the healthcare sector. And also, he plays has a particular interest in certain elements of the strategy, so really trying to help us focus and bring that to ground. The government's also been thinking in Ontario about implementation of a strategy, so wanting to make sure that there is a foundation in place once there is a public strategy, so that we have an implementer for that and for the strategy and for the investments. And so they've introduced into our legislature an act that really introduces a single point of contact and a single point of accountability, oversight, and quality for mental health and addictions. And so that is the Centre of Excellence for Mental Health and Addictions inside the new Ontario Health Organization. So that'll help drive that piece forward from a foundational piece. And then finally, I should mention, lastly, by way of context, that in terms of capacity, last year the government invested $174 million in annual funding into direct services. And when I say last year, my mind is already moving forward to next year. So that was for 2019 and 20. The idea being there that we want to make sure that there is direct mental health and addiction services, more of that available for clients and families who need it. So then moving from general context into a structured psychotherapy program that we've also been piloting, so a bigger program within which iCBT fits. So what are some of the reasons, and I'll just be very brief on this, that a government might want to think about piloting structured psychotherapy? The first, obviously, is that anxiety and depression affect lots of folks. About 20% of Canadians at some point in their life have this condition, struggle with it. And also it has big impacts monetarily wise. About $50 billion annually across the country if you add up healthcare costs, social costs, economic costs, et cetera. So obviously something that the government wants to think about and be certainly piloting solutions for. So over the last number of years, stakeholders and partners, this would be hospitals, community partners, et cetera, have come to the province and said, we really need to help you understand the need across the lifespan for some solutions that could potentially help folks struggling with these two issues. And so in 2017, the government announced that it wanted to pilot a program, and we looked around the world at various jurisdictions that were in this space, and we thought that there were certain elements, particularly in the United Kingdom program, that were particularly high quality and evidence-based. And so we've modeled a bit of our pilot after that approach. After about 2.5 years now of piloting, what are some of the places we've come to? The first is that we have 4 regional psychotherapy networks in Toronto, Ottawa, Muskoka, and Central Ontario. They are now up and running where they were not before. There's about 140 clinicians at work, and they are working across 80 different locations. And when I say 4 networks and 80 locations, we really wanted to make sure there was a distributed approach so that those clinicians are in not only hospitals, but also in community providers, family service organizations, et cetera. Sorry, I just got a tickle in my throat. We've also developed a clinical model that specifies which conditions and which treatments the government will fund. And we've also developed a training and a clinical consultation model so that we have kind of a best-in-class quality approach for the clinicians. We're also measuring client outcomes. At present, across the 4 hubs, we are seeing client recovery rates that are pretty strong, and they're growing. We've only been at this for a couple of years, but we're seeing rates that are getting closer to the United Kingdom at this point where they were in their program. Finally, the program leverages a stepped care pathway that employs lower intensity tools like Bounceback, as well as higher intensity tools like group and in-person one-on-one cognitive behavioral therapy. So really trying to situate it within that program. How does CBT fit into this program as a whole? So I should say, apart from mental health and addictions, Ontario is emphasizing investments in digital health to make healthcare more client-centered, to drive access to healthcare in a way that makes it really simpler for consumers. So this involves trying to be innovative, but also trying to do this in evidence-informed ways, and so the mental health and addiction space is no different. So as we've already heard today from David and from some of our other panel members, the evidence that we've looked at says that iCBT, and specifically clinically supported iCBT, can be a really both clinically and economically beneficial route to pursue. So after looking at the various pieces of evidence and asking partners, what we did is create a vendor of record for iCBT, and we procured 2 vendors, 2 platforms to situate within that broader structured psychotherapy program. We also made some decisions about who were the client groups that we wanted to focus on. So we were in conversations with colleagues at the Ministry of Training, Colleges and Universities, and decided to go with college and university students for a number of reasons. The slide will show you that a number of students, of course, feel anxious and depressed as they are dealing with their lives and the situation, but also these clients in particular show a strong preference for independent and self-directed approaches when such options are available. And I don't have to say, and we've heard some really personal experience today, that I think these clients in particular are highly literate digital natives, and not only is this kind of tool effective for them, but it's also quite comfortable and natural, so I wanted to move into that space. very quickly, I've got a bit less than a minute left, some implementation elements that we've been thinking about as we've been moving through this process. The first, as I've mentioned, is based on the evidence, the desire to focus on clinician-supported iCBT. Second, we didn't want to have this pilot sit out on its own. While there is very strong evidence for iCBT, we also know that there's lots to learn, so we wanted to make sure that the clinical leadership team within that broader program, as I mentioned, was there to provide some oversight, advice, and leadership for the iCBT pilot. As I mentioned, we're starting on university and college campuses, and we're doing that in combination or situated where the original 4 networks are. And there's an important reason for doing that. We wanted to make sure that this was supported by a stepped care pathway. And what I mean by that is, of course, not all clients will succeed with low intensity tools. So we want to make sure that there was a stepped care pathway around that these folks could be supported by in case they were unsuccessful. And also important, wanted to make sure that they have, to not have to start an entirely new clinical pathway, that they had the supports of that piece overall. 2 last quick things. As I mentioned earlier, we are using a measurement-based care approach inside the overall program. So that means at each session, the client completes mental health screening tools. We really wanted to focus on making sure that our platforms conform to that approach as well. And then finally, by way of implementation, we are conducting an evaluation of this pilot, and I'll leave you with this last slide with some of the things that we've learned and some of the questions that we're trying to source in our evaluation. Thank you so much.
Very useful information, Patrick, and always useful to have the ministry perspective on this, so thanks very much. So now from Ontario, we're going to move to the west and Saskatchewan. So we're going to hear from Dr. Heather Hadjistavropoulos. Dr. Heather Hadjistavropoulos is a professor of psychology at the University of Regina and founder and executive director of the Online Therapy Unit, which has been delivering and evaluating iCBT in Saskatchewan since 2010. She's also principal investigator of the Public Safety Personnel iCBT team, responsible for a $10 million agreement with the federal government to implement and evaluate iCBT for first responders and public safety personnel. Her innovative work in iCBT has leveraged millions of dollars in funding. She has published and presented extensively on how to reach, effectively deliver, and disseminate iCBT, and has shown noteworthy leadership in understanding, assessing, and optimizing therapist guidance in iCBT. Dr. Hadjistavropoulos' significant and innovative contributions to digital mental health make her a recognized leader in the field in Canada and internationally. And Heather has contributed to the CADTH HDA as a clinical expert. So welcome, Heather.
Thank you.
And we can hear you. Great. Welcome. And I can advance your slides if you prompt me to.
Okay.
Thanks.
Thank you. Well, thanks for that lovely introduction. If I was there, you would see me blushing. I really want to thank you for asking me to be part of the session. It's great to see the increased interest in iCBT. As you mentioned in the introduction, my journey with iCBT began quite a while ago, so it's actually about 10 years ago now. As a professor of psychology, I was training students in cognitive behavior therapy and also researching CBT. And in reading the literature, I really was starting to notice strong results, specifically on therapist-assisted iCBT, especially out of Sweden and Australia. What I noticed, though, at the time was that there was really a lack of research on how iCBT works out of research studies when you put it into clinical practice, and started to wonder, whether we could actually get the same results if we put it into practice. So I decided to take on that challenge, and it really has been kind of a 10-year experiment since then, lots of tweaking along the way. I'm really trying to figure out how to bring iCBT to Saskatchewan to, as you can see in this picture, kind of fill in the potholes in obtaining care that exist because of things like rural and remote location or limited time, stigma. Next slide, please. So I was fortunate to secure a CIHR Partnership for Health System Improvement grant that allowed me to form the online therapy unit. And with this unit, what we planned to do was deliver ICBT, but also educate professionals and students on how to deliver ICBT, and then to conduct research on how to best implement ICBT in clinical practice. And this was actually quite a challenge because when you read research trials, it doesn't tell you all the nitty-gritty of how to actually do this and how to educate professionals, what they need to know, how to actually deliver things. Our early work, though, was quite successful, and very soon after we started, SaskHealth started to fund the online therapy unit on a consistent basis. And then we've been continuing to get grants to continue our research that helps us figure out how to optimize ICBT in clinical practice. I just want to show the next slide. It could probably take me an hour just to go through all of that, but it's really just to show that it's been a huge team effort to implement ICBT in Saskatchewan. So have had lots of help from students, colleagues at the U of R. I've benefited tremendously from collaborating with different researchers, both in Canada and internationally. A huge shout out to my partner from Australia at Macquarie University, Nick Tidos. We've also partnered with community mental health clinics, had great luck in getting funding. And then the star there has really been our patient partners. We're very fortunate to have patient partners who really help us make our service better. Next slide. So what might not be clear when you hear about ICBT is actually there's so many different ways to deliver ICBT and many, many different types of programs. In terms of our approach, it's typically an 8-week program with lessons released gradually over time. In terms of therapist support, we have registered providers with a background in psychology or social work, primarily, as well as some graduate students under supervision. And our typical model is that these therapists provide support through messaging, and it's usually once a week message over the course of 8 weeks. In terms of who we're working with, it's adults that we're focused on, primarily residing in Saskatchewan, although we do have a few programs that are available to everybody in Canada, actually. So we have a chronic conditions program that is health educator. It's not therapist assisted, so it's more self-directed. And we also have an alcohol change course. Just in case you're interested, those are available to everybody. We work with clients who have depression, anxiety-related disorders, and alcohol misuse. Of course, you have to have a computer with internet. In our case, we do ask clients to give us a healthcare professional contact for emergency purposes. And we do a screening that screens out people who would be at very high risk of suicide, but of course some risk is also present. We screen out for significant problems with drugs, psychosis, or mania. This is a bit of a detailed slide, and I won't go into all of the details, but it kind of shows our progress over the past 6 years. The very first years were kind of slow going, getting things off the ground. But in the past 6 years, we've worked with over 6,000 clients, and it keeps increasing each year. So you can see in 2018, we did 1,500 telephone screenings and 1,000 clients treated. In the last 12 months, that went up to 1,900 telephone screenings and just over 1,300 clients accepted. When clients aren't accepted, we play an important role in the system in terms of helping people navigate the system and look for alternative services. In terms of therapist support, we have therapists within our unit that deliver services, but we also have had clinicians who also who work in community mental health clinics who are trained to deliver ICBT. The next slide. The programs, we have a number of different programs, but the main courses that we're using do come from Macquarie University, and they've been adapted for use in Saskatchewan or Canada. As I mentioned before, it's an 8-week program. There's 5 core lessons, but there's also additional resources to the extent that they're needed. And they cover the typical content that you would expect to be covered in a CBT course. So education, thought challenging, managing physical symptoms, rated exposure, and relapse prevention. One thing that we've really found that the research has been important is helping us kind of tweak iCBT over time. So what we've noticed is that where we started is not where we're at now, and that it's through research that we've refined a process that we feel is getting good outcomes and also is efficient and results in sort of few difficulties. So our screening process has substantially changed over time. Initially, we were very focused on diagnosing clients. We've moved more to screening clients and using symptom measures. We've changed in terms of inclusion criteria. We now have more clients that are in the severe range than we previously had. Our programming has changed significantly. So when we started off, we were very focused on disorder-specific programs, and now all of our programs have a transdiagnostic component to them in the sense that they address more than one problem, so anxiety and depression. And also, we moved from 12 lessons to 5 core lessons, just with the idea that more is actually not better necessarily. More is sort of, what we were finding is that we were offering these 12 sessions, but that was sort of more than what clients would want. We've learned a lot about therapist assistance and how to help therapists deliver iCBT, and created a lot of scales that help us monitor and train our therapists. And we've also made some changes in terms of using specialized versus non-specialized therapists. So what we've really learned is that for efficiency and consistency and sort of quality, it actually works quite a bit better if your therapists have the time to really focus in on this and are not sort of multitasking. We still have much more to learn. The next slide, please. So we have a lot of research that's still ongoing that's really trying to help us. Could you go to the next slide, please? Anyways, okay. We have a lot of research that's ongoing and trying to help us understand what's the best or optimal level of therapist support, which clients need more support in terms of like one business day support, once a week versus twice a week care. We're also working on different stages of care, so programs around motivational interviewing, things to help clients work through homework, and then the idea of booster sessions or follow-up care. We have quite a bit of research going on right now around how to help clients with alcohol problems, sleep concerns, and coping at work. And we're really trying to understand the needs of some specific populations that have some unique needs. So public safety personnel, postpartum depression and anxiety, post-secondary students is actually an interesting one that overlaps with other directions that I heard today. Overall, what we found in terms of our courses that we're getting really strong effects. This one slide, the next slide after the tree slide, shows we're having large effects that are very similar to those that are obtained in face-to-face treatment, as well as the research trials of iCBT. So people starting in a clinical range and ending up in a non-clinical range. Some things that we're particularly proud of are about 26% of our clients tell us that getting online therapy was their first time getting care. So we're reaching some people who weren't getting care before. 95% of our clients are telling us that they're very satisfied with care. we have very high completion rates. And again, it's something that we've really worked on through our research to try and figure out what are the strategies that help clients move through the program. So 84% of our clients are completing the courses, and we're seeing about a 50% reduction in symptoms. And if you go to these we're behind a few slides here. I don't know if we're just off on timing, but I'm on the slide that shows the map of Saskatchewan. Something that we're very pleased about is when we first started off, we were hitting mostly clients in Regina, and this is actually now expanded to across the province of Saskatchewan. So we know that iCBT is reaching people who would normally not have access to CBT. And so on that note, I'd just like to end. And again, thank you for inviting me to be part of this session. I really appreciate the opportunity to tell you about the work that we're doing in Saskatchewan.
Great work, Heather, in Saskatchewan. Thank you to all the speakers for sharing your experiences and information around iCBT work in Canada. Much appreciated. So now we have a few minutes left, and we can perhaps turn it to you, the participants, for any questions you may have for the speakers. Again, for those people in the room, there is a microphone, and we can pass it around if you like. For those online, please send your email, your questions by email to ashleyb@cadth.ca, ASHLEYB@cadth.ca. And if you can please indicate the name of the presenter that you're asking the question to, that would be helpful as well. So yeah, let's get started.
Okay, so if there's no questions in the room, maybe I'll start with a question that came in from online. So the first one here is, with the abundance of apps out there, what should people be looking for to ensure that they're accessing truly evidence-informed therapy in these apps?
Who wants to go first? Dr. Gratzer?
No, please.
There are a lot of apps. There's a recent study out of Ivy School suggesting there are over 300,000 health apps. Of course, a health app isn't necessarily a mental health app, but even if one were to narrow the search down, there are tens of thousands. At this point in time, it's difficult to pick and choose. One might look at more traditional ways of sorting out a good app from a not-so-good app, such as starred reviews and so on. Turns out that there's not that much evidence for that. There's a paper in Nature recently suggesting as much. So you're online, perhaps you or a family member has mood or anxiety problems. You're looking for something evidence-based, evidence-informed. Here might be a few things that would help you out. First of all, the APA has done good work in this area, and they have some further suggestions, but I'd suggest three really quick things. One, is there any sort of a university affiliation or work with experts? Two, is there any evidence to support this app? So have they ever had a paper studied suggesting results, or several papers studied suggesting results, or do they simply feel that their app works? And the third thing, to tie back to something I had said before, look for a digital privacy policy and make sure it makes sense to you. Of course, not all of us are lawyers. I certainly am not. But if the policy doesn't seem right, could be a flag. Can I add one more point? Sure. And of course, the other thing to think about larger is, what are you looking for in an app? There are a lot of apps out there. Some might help you simply organize your medications. Some might help provide you information on depression or anxiety. And some might do cognitive behavioral therapy. So think a little bit strategically, as you would, I suppose, before any purchase, in what you're hoping to buy, even if it's just a $3 subscription.
Thank you.
Hi, I'm Ali. I'm from OPT. We are empowering the mental health provider to offer digital CBT. So one of the quick questions, we are not declaring ourselves. We are helping the providers in the public system or private system to offer it. And one of the questions always coming up is that, okay, what is the incentive for me? I already have I'm overwhelmed with patients. Why I should go over, internet to doing it when we are saying that, okay, it's going to be 1/4 of the time we can see the more patients. Unless someone is really into it, they don't buy that argument because they said the economy is not there. The hospitals see us as an extra cost at many times, say that, oh, okay, I'm not getting more investment from the government for implementing digital CBT. Yes, it's because I'm not paid by per person. I'm paid by hours. All of my psychiatrists are full and this kind of thing. So what the government is going to do to incentivize it, because essentially the government is saving, because if psychiatrists or social workers or nurse or psychologists seeing more patients at the same time, it is saving the government. So do you have any quick answer to that? I know it's kind of hard to answer, but yeah, that's the kind of question always comes.
No, I appreciate the question. I would give you a two-part answer. First would be you probably shouldn't take investment decisions or advice from someone who works for the government. So you'll have to kind of manage your own piece there. I would say that as part of an element of a broader strategy, the government is very interested in psychotherapy. That's why we're piloting for the past 3 years. We have gotten lots of good evidence that iCBT can form a really important part of a stepped care pathway. There's been lots of eloquence on that today. So the second part of that would be, the government is interested and is trying to figure out, is it an evidence-based piece? From there, there'll be some potential investment decisions, and you'll have to sort out your investment, forward movement on that piece.
The main question is that, are you going to reimburse the people for the same amount of hours in the higher rate than their traditional way of seeing it? Because they're saying that essentially I'm bringing more efficiency. Do I get part of that efficiency that I generate for the system? That's kind of always a question. And one of the challenges is that how much you should reimburse 15 minutes of digital CBT compared to the 15 minutes of face-to-face visit.
Right. So I think I may not get your question correct, but I think part of that is embedded in what are the kind of contracts the government has going forward, what are the kind of service contracts that service providers have with providers of internet-based cognitive behavioral therapy, and inside that is a bit removed from the decisions certainly that we're making around a strategy, but happy to have anyone else comment.
We have a few minutes here, so I wonder if Byron, you would like to share very briefly the experience of iCBT in Newfoundland?
Can you hear me?
Yes, we can hear you. So
Yeah,
maybe
so
2 or
here
3
in
minutes.
Newfoundland, well, I'll give a brief overview. Here in Newfoundland, we've been on a bit of a journey to transforming our mental health addiction services system over the last several years. There was a all-party committee review that was completed through our provincial government that looked at a lot of different areas of the system and how we could really improve. And there was a series of recommendations that came out of that, many of which pertain directly to technology and how we can leverage technology to better meet the needs of our individuals here in Newfoundland and Labrador. So part of that was embarking on a demonstration project to look at the place of e-mental health strategies in the system. And that project finished up and the report was released back in September through the Mental Health Commission of Canada. And a part of that was looking at iCBT and how it fits in our system here in Newfoundland. So since early in 2018, we've had a publicly available access to iCBT programming here in Newfoundland. So we have the two-prong approach, as was discussed earlier in the presentation, where we have open access, unguided iCBT. So there's modules, educational modules available for individuals who can work through them individually with no clinical intervention by an individual. So individuals can get on our provincial mental health website, bridgethegap.ca, and access that. And then we also have clinician-assisted as well. So we use TAO platforms, so Therapy Assisted Online, and our clinicians who are government employees, so they work for our local health authorities, they just use that platform to deliver the service. partner with individuals who are interested in completing iCBT through that program. And essentially, they do module by module a process as was kind of described earlier. So usually a module is prescribed to the person one per week, and then they meet with the clinician for a brief session, 10-15 minutes, to discuss what they've learned, what they've done in the last week, to go over logs, talk about what has worked, what hasn't, and then the next module is assigned, and then they meet again in a week's time. We've seen some success here in Newfoundland simply based on the fact that we have a varied geography which has already been discussed, and we also have lots of other factors, I guess, that contribute to the effectiveness of iCBT for our individuals. You look at personal situations, socioeconomic status, but a lot of it ties back to geography. So we have many mental health and addiction services offices across our province, but we still have a lot of outlying population who live vast distances from those offices. So it could be an hour and a half, 2-hour drive. And then you have individuals who do not have they have transportation. And obviously, when you're talking about that type of geography, there's no public transportation. So it can make it very difficult to access services. And it was already alluded to in discussion that, one example was a single mom who says, I simply don't have time during the day to leave my kids to go to a traditional 1-hour therapy session. She's indicated that it would be very troublesome to find a babysitter, get ready, go to the appointment, come home. Now she talks about her experience with iCBT. She can be with her kids. She can get her kids ready for bed. And then she can sit and do her work that she needs to do and learn the skills. And then it's not an issue for her to kind of have that 10 or 15 minutes to meet with her clinician when it's convenient for her. So right now we're kind of in a continued build-up phase where we're really trying to help people in Newfoundland kind of understand what their options are and help them recognize what is available to them, and kind of working through that, kind of what we've talked about, gaining the trust in that type of a program. But it's been going well, and we're looking forward to continuing on with that work here in the province.
Great, thank you, Byron. Great information from Newfoundland being publicly available for everyone there. So great work. I believe we have a question in the room.
Hello, my name is Janet, and I am a patient advocate. I've had the chance of participating with one of the HQO standards for chronic pain, but I also I'm a patient health mentor for UFT and interprofessional education. So health is mental health has been one of the things that I've been advocating. My concern is, after I've heard every single presentation, which is really very good, thank you, and for the work you do. My concern is further marginalizing those who are already at the margins. I didn't see those groups mentioned or any references made to them, so I'm going to assume that maybe the study has not yet been done. I have heard a lot about this is going to be faster, this is going to be cheaper, this is going to be more accommodating, but we're leaving, for example, in the province of Ontario and a couple other provinces, we have the Accessibility for Ontarians with Disabilities Act that mandates that any information communication should be fully accessible. So deaf people, how can they hear this? I've emailed a few of my deaf friends, and I noticed that there were some slides that were not read out, so I don't know how that is being navigated. There's deaf people, there's people with cognitive disabilities acquired or born with. Not to mention folks who are racialized, and are they going to be receiving therapy or advice, or is the ear hearing to their anxiety? Will they be able to understand what their situation is? The same goes for Indigenous people, people who don't speak English. I'm an immigrant. Folks who are homeless. I imagine that their mental health may not be the most optimal. And people in prison who usually are highly racialized. So are we furthering reinforcing and reestablishing the racism and exclusion and ableism in our attempt to actually do something better for mental health.
So let me take the first shot at that, and thank you for that question. It's a really, really important one. Let me answer it in a couple of ways. The context that I tried to give for the iCBT pilot was to place it within the context of a pilot for structured psychotherapy that has been going on for the past, let's say, 2.5 years. I think we've tried very hard within the province in the scope of that pilot to make sure that the groups that you've mentioned, particularly marginalized groups, are really represented in terms of the client base, and that we are modifying the therapies in order to reach them. So I think in terms of the overall program, we're working very hard to do that, and I can speak at length about that. I should also go one level further and say that, I'm going to go 2 levels further and say that I mentioned that this iCBT pilot within the structured psychotherapy pilot was part of a broad number of investments the government's been making over the past couple of years. One of those investments, for example, was to have more supportive housing supports for individuals who are justice involved. And so it's one part of a suite of investments that the government has its eye on. And as I mentioned at the, one more level, at the broadest level, as the ministers of mental health and addiction have been going out across the province, we tried very hard to make sure that we hear input from Indigenous partners, we hear input from folks with accessibility issues, really want to get that advice, and I'm very confident that as the government moves forward with its broader plan, I mentioned a $3.8 billion investment over 10 years, that they will work very hard to ensure that those voices are heard and that there are services in place for those folks, and I'm happy to have an offline conversation about the various elements.
And if I may add, from an evidence perspective, the review did not specifically look at that, but we did consider those aspects in our review, especially when it came to patients' experiences. And I mentioned briefly in the ethics review that it's not something that enhances access for everyone. And for the implementation considerations as well, we did consider being offered in various languages or considering cognitive abilities of participants. We did not specifically look at those aspects, but they are mentioned in our reviews as considerations as well. So thank you very much for this comment. It's very important. Thank you.
We've already had a discussion. I'll just add very quickly. Important comment, important from a research perspective, important from an implementation perspective. I would suggest, though, that if we're smart about things, maybe technology can bridge some of those divides. Let's not oversell. But if you are 2 hours north of North Bay, your ability to find a therapist who speaks Tamil or Cantonese, I'm suspecting, would be quite limited. So again, that doesn't necessarily mean current products do that, but maybe in the future, though, of course, marginalized populations need more than an app.
Heather, any comments from you, maybe? Heather, any comments from you?
So I think just in the interest of time, I do think we will have to wrap up the live stream component, but we will have some time after for folks in the room who do have questions. And we do have several more questions that have come in online as well, but perhaps I can forward them to the panelists who I think would have the best insights on those questions, or to several panelists in some cases, and we can be sure to get back to everyone after the event wraps up.
Thank you, Ashley, and it's really great that we have questions. This is what we're looking for. So we're running out of time, unfortunately, so just a few closing notes from us. CADTH is continuing its work on iCBT, and we're doing a review right now on iCBT for post-traumatic stress disorder, and please keep an eye on our website. The report and the recommendations will be complete early in the new year. We have some resources available on our page, CADTH.ca/ICBT, some summary tools and brokered information if that's of interest to you. I would like to remind all of you that we have liaison officers across the country, and here in Ontario we have Elizabeth Smitko, so please feel free to connect with your liaison officer if you have any questions or areas of interest that you would like us to explore further. And finally, I would like to acknowledge the many people who have contributed to this work, the presenters and participants today, the research teams at CADTH and HQO, the HTERP and OTA committees. And when it comes specifically for this event, I would like to thank my colleagues, Elizabeth Smitko, the Liaison Officer for Ontario, Ashley Baddeley, for the Program Officer for our implementation support and knowledge mobilization team at CADTH, the CADTH events team, and the CADTH and HQO communications team. And perhaps we will see some of you here in Toronto in April for the annual CADTH Symposium. The theme this year is Decision Making in an Age of Uncertainty, from April 19th to 21st, 2020. So thank you very much for being part of this event. Thank you for your questions and your participation, and I hope everyone has a great afternoon. Thank you very much.